Hello, my name is Andrea Penrose, and I'm going to be talking today about some real-world data with Nirogacestat that we've taken here at Northwestern Medicine. I'm a research assistant who's been lucky enough to work with the sarcoma team here over the last year, and I now work at the NCI doing some research with them. I won't go too into depth on the background of desmoid tumors, as we've had some really excellent background already. But I just want to highlight that Nirogacestat was approved in November of 2023, so it's turning almost 2 years old, and it's a gamma secretase inhibitor that was approved in the DeFi phase 3 trial, and we had about 70 patients on the intervention arm in that study, showing about a 41% objective response rate and a PFS that couldn't be measured in the intervention group due to not a long enough time period. Median time to response for patients on Nirogacestat is around 5.6 months, which is about half of that amount of time compared to the placebo arm. And when we look at the patient-reported outcomes, as we've talked about, is maybe the best measure of what we can look at response right now, we see some really great signs of early improvement and quality of life. However, since Nirogacestat is relatively new, we have a need for real-world data on dosing, adverse events, and patient-reported outcomes. So our goal with this study was threefold. First, we wanted to look at how patients started treatment and what doses were used. Second, we wanted to track and manage side effects and evaluate early patient-reported outcomes like pain relief and day-to-day function. We wanted to see not just what happened in the medical record, but also how patients themselves were feeling. So we conducted a retrospective review between January 2024 and March of 2025, which included around 16 patients, not around 16 patients, who are largely treatment resistant, but we had some patients who started directly on Nirogacestat. And we had a large symptom burden with our patients. So we pulled information from medical charts, including tumor size, location, prior treatment, side effects, and we looked qualitatively at the charts for their patient-reported outcomes. So we had 16 patients included in this study. Our median age was 41 years, and we ranged between 26 and 67, which is pretty reflective of what we've seen in other studies and what people have reported so far today. Tumor sites included abdomen, neck, extremities, chest, and abdominal wall, which is pretty, again, reflective of the real-world data that we've seen from everybody today. About a third of our patients had multifocal disease, meaning that they had tumors in multiple locations, and about half had already tried other treatments, including surgery, chemotherapy, TKIs, and radiation. 3 of our patients had a history of FAP, which is important due to the correlation between FAP and desmoid tumors, usually after surgery. In short, this was a diverse, heavily pretreated group, which was very representative of the real-world population. So almost all of our patients, this is the kind of breakdown of where our patients fell with prior treatments. Our median follow-up time was 42 weeks. Okay, great, there we go. So almost all of our patients started on the FDA-approved dose of 150 milligrams twice daily. We had 1 patient start on 50 milligrams and titrate up to 150, and nearly half of the patients had a brief treatment pause at some point, and about a quarter of those needed a dose reduction. Importantly, we had no discontinuations due to adverse events, which is very important, especially when considering with our data presented earlier today, like sorafenib, about a third of our patients had treatment discontinuations due to adverse events. So this suggests that the FDA-approved starting dose is feasible in practice, even though temporary adjustments are sometimes needed. And our patients who did need dose reductions tolerated 150 or 100 milligrams twice daily very well, suggesting that the side effects are related and maybe correlational to how the treatment dosage. So just kind of taking a closer look at why the couple patients needed a reduction. We had one patient who had a rash and they tolerated 100 milligrams later. We had two patients with pretty severe diarrhea, one combined with fatigue. They both tolerated 100 milligrams quite well, and one of those patients titrated back up to 150 milligrams and tolerated it well. And then almost half of our patients had various dose interruptions, but importantly, no discontinuations. We did have one patient who discontinued therapy after a radiographic response. They chose not to resume therapy, but they did not have any serious adverse events that would have caused them to discontinue therapy. When we took a look at our most recent follow-up in March of 2025, we had 50% of our patients with diarrhea, which is less than when looking at the DeFi trial. I think it was like 85% there. But the rest of the side effects are relatively reflective of the phase 3 trial. So we had almost half of our patients with rash. We had a couple patients who needed a phosphate supplement. 2/3 of the women of reproductive age had some form of ovarian toxicity. And we had one patient with hidradenitis, which is a skin infection kind of the sweat gland areas. And importantly, that occurred later in treatment and was not in the first couple months. We also had two patients who had some sort of upper respiratory infection or gastrointestinal infection, which we think may be related. Nirogacestat can cause overproduction of mucus and goblet cells, and so we think these infections may be related to that. And we had one patient as well with a liver toxicity that caused them to pause treatment. So our patients, 62% of them reported improved pain and functionality, which is very significant, right? And 94% of our treatments, or 94% of our patients remain on treatment at the time of follow-up. And this suggests kind of that our patient-reported benefit, in addition to clinical measures, is very good with nirogacestat. For clinicians, this gives us the confidence that starting at 150 milligrams twice daily is appropriate, and that most side effects can be managed without stopping treatment. For patients and families, the key takeaway here is that many patients start to feel better in just weeks, and the medication has been very well tolerated in real-world use. And just to kind of summarize the whole thing, nirogacestat is very well tolerated with manageable side effects. Most patients were able to stay on treatment at full dosage, and many experienced real improvements in pain and function. This real-world data supports the FDA-approved dose and offers encouragement that this therapy is a meaningful option for patients with desmoid tumors. So, thank you very much, and yeah.
One quick question. Sorry.
Yes.
So all the patients on your review started at 150?
We had one patient who started on 50 and then titrated up to 150. We were concerned about side effects with them, so we started low and kept going up.
Yeah, congrats for getting this done. This very much reflects what we're also seeing. So I think, you know, this is, I hope you get this published.
Thank you.
It's really good, yeah.
Any other questions? Oh, yep, go ahead.
Do you have T2 data on any of the patients that decreased their dosing?
I was sitting there thinking that T2 data would be a great thing to pull for these patients and very, very reasonable. So if we do decide to publish it.
Yeah, we actually brought it up with our radiology team because they're working on some stuff, but nothing yet.
All right, any other questions? Okay, thank you guys very much.